Hello, I'm Amanda Buttery and welcome to this Heart Foundation and Royal College of General Practitioners webinar on the diagnosis and management of atrial fibrillation. I would like to acknowledge the traditional owners of the land on which we meet today, and I would also like to pay respects to elders both past, present and emerging. So for the next 45 minutes, we'll be focused on the diagnosis and management of atrial fibrillation, and we'll be referring to the National Heart Foundation of Australia and the Cardiac Society of Australia and New Zealand's clinical guidelines for the diagnosis and management of atrial fibrillation, published in 2018. We've got a great lineup of speakers for you today, and we'll be using a case study to discuss key practice points and common clinical challenges arising in the management of patients with atrial fibrillation in general practice. So without further ado, please let me introduce Dr. Atef Asham, who is the chair of the RACGP Cardiology Specific Interest Group, who will introduce our presenter and will describe how the session will run.
I would like to thank the National Heart Foundation for the great work it has done, and I hope it's the beginning of an ongoing relationship with our college. For those who are not aware, the RACGP Specific Interest Cardiology is a growing group, almost 1,500 GPs. So far, with a special interest in cardiology established in mid-2017, and we hope we can get more GPs who have specific skills or interest in cardiology to join us. This year, the GP20 conference has a different twist. It is a virtual conference. One of the many challenges we have risen to in general practice over this year due to the COVID-19 pandemic. Today, we have a presentation on atrial fibrillation, especially from a general practice perspective. By the end of this presentation, we will give our interest the tools and the knowledge to apply best practice recommendation for screening and prevention of AF in the community, describe evidence-based strategies for diagnosis and management of atrial fibrillation, and explain strategies for the prediction and management of stroke risk associated with atrial fibrillation, including consideration for anticoagulation therapy. We are lucky to have Professor Nick Zwar to present our atrial fibrillation session. Professor Zwar is an author of the 2018 atrial fibrillation clinical guidelines. So Professor Nick Zwar joined Bond University in 2019 as Executive Dean. Nick's background is in medicine as a general practitioner and as a primary healthcare teacher and researcher. Nick was previously Dean of Medicine at the University of Wollongong, and prior to that, Professor of General Practice and Deputy Dean at University of New South Wales. He has a national and international reputation in health services, research on prevention and management of chronic illness, especially with focus on respiratory and cardiovascular disease. Other clinical and teaching and research interests, including tobacco control, immunization, and travel health. He's actually currently the chair of another specific interest group, RACGP, Specific Interest Travel Medicine Group. Professor Zwar has led the development of and contributed to several sets of Australian and international clinical practice guidelines and has over 200 peer-reviewed publications. For the next about 30 to 40 minutes, you will hear an interesting presentation on AF update from Nick, and there will then be some time for Q&A, I hope. Please join me in welcoming Professor Nick Zwar.
Thank you for that welcome, Atef, and thanks for the Heart Foundation for inviting me to do this presentation. As Atef has said, I'm a general practitioner by background, and I'm talking about this topic as a GP who's had the good fortune to be part of the guideline group for the publication on the diagnosis and management of atrial fibrillation. But I'll just be clear, I'm not a cardiologist, and some of the content is quite detailed, and we'll give a GP view on that, and of course refer to the guideline itself for further information. So yes, diagnosis and management of atrial fibrillation. I'll just start out by saying I've got no competing interests to declare in this presentation. So yes, as has been mentioned in the introduction by Amanda, the publication from the Heart Foundation and the Cardiac Society of Australia and New Zealand came out in 2018 on diagnosis and management of this quite prevalent condition an important condition in our population, particularly in older people. It was informed by evidence, very much so, and an evidence review, and that was interpreted and thought about and synthesised by local experts from a range of disciplines, including general practice, cardiology, clinical pharmacology, a consumer representative, etc. First Australian guidelines on this topic, and it used the grade methodology, which some of you will be familiar with, and quite a lot of the College of GPs publications now use the grade method of grading recommendations, assessment, and evaluating evidence and coming to a recommendation. And in that recommendation, in the grade system, it's either weak or strong, and it considers the quality of the evidence behind that recommendation. And recommendations can be for or against. They're not necessarily only for some particular therapeutic thing or some action. So atrial fibrillation prevalence is increasing, and this is a lot to do with ageing in our population. It's the most common recurrent heart arrhythmia. Atrial fibrillation and atrial flutter was underlying cause of over 2,000 deaths in Australia in 2018, which is really quite a substantial total when you think that 6 deaths related to either atrial fibrillation or atrial flutter each day. A growing burden, and of course hospitalisations, healthcare costs are increasing. And as you can see, 10 to 30% of people with AF admitted to hospital each year of cardiovascular and non-cardiovascular causes. So quite a common reason for hospitalisations or attendances at hospital. As you can see from the diagram, a reminder of the heart physiology and normal sinus rhythm versus what's happening in atrial fibrillation with the chaotic electrical signals moving around the atrium rather than coming from the sinoatrial node and then getting through the AV node and having disorganised fibrillation of the ventricle as a result. So many people with atrial fibrillations are asymptomatic, and this is an important point because we may not think about this. Of course, the person that comes in and says they've got feelings of fluttering in their chest and they're feeling a bit short of breath and they're 75, of course we would be thinking about atrial fibrillation as a possibility straight away. But in older patients particularly, it may not be symptomatic, and you can see there those in both men and women, and how common the asymptomatic becomes as people age, and how important proportion, particularly in that age group over 80. And that's part of what we'll talk about today. So we're going to sort of work through a case study as we go through today, and Atif and I will talk about this in our question and answer at the end. But we'll start off with Mrs. RC, 67-year-old woman, presents for a routine checkup. Maybe she's come for her blood pressure medicine, or maybe she's just come to have a talk about how she's getting on with her health. Blood pressure's been well controlled, and she's just on Perindopril 5 milligram daily, so just a calcium channel blocker, and her BMI is 30, so a little overweight, but not uncommon. And the question is, would you screen this person for atrial fibrillation? And if so, how? So food for thought. You might not think about that in a 67-year-old as being something you would come to mind, but in fact, the recommendation from the guideline is to screen all patients over 65 and confirm suspected AF with an electrocardiogram, and then to work up diagnostic workup with echocardiography and thyroid function tests, and identify and manage intercurrent risk factors and comorbidities. So I think that the age is important here, because we might be more inclined to think in someone over 75, oh yes, AF's getting pretty common, but in fact, AF starts to become sufficiently prevalent to think about screening from age 65 and over. So opportunistic screening in this kind of age group, or 65 plus. Previously unknown AF, this important point, is associated with about 10% of all ischemic strokes. So people who turn up in hospital with a stroke, or turn up maybe to your clinic and then you refer them on, about 1 in 10 of those people have AF that was not previously recognised. So that's a considerable burden of ischemic stroke, which could have been preventable. And you can see 1.4% of patients in community or practice situations over 65 will have unknown symptomatic AF on a single time point screening of pulse ECG. So not a really high pickup, you know, not incredibly common. We're talking about, you know, just over 1 in 100 patients, but nonetheless, I mean, that's important when a preventable thing like a stroke is something, and a serious thing may be possible to intervene. And stroke risk is actually similar for asymptomatic and symptomatic AF. So that's, again, something we may not have thought about, that those patients who don't realise they have AF are just as much at risk of having a stroke as those who do know they have it. So this recommendation comes out of all of that background and literature, and opportunistic point of care screening in the clinic in people aged over 65. And it does, you know, meet that justification for screening because we've got something we can do about it. We can intervene with a range of things, including anticoagulation if necessary, and try to prevent a serious outcome. There's a range of ways of doing the screening. Pulse palpation is obviously the most straightforward one, is to, when you're taking the blood pressure or when you're talking to the patient, put your fingers on the pulse and, you know, have a think, is this regular or not regular? Sometimes our blood pressure machines as well, of course, will give you an indication, not all of them, but some do. But it does need to be confirmed with a ECG if it's irregular, if you suspect that it's not in sinus rhythm, an ECG rhythm strip, and that can be by a 12-lead ECG or can be a handheld ECG. You may do that as part of your routine consultation, like this patient when you're checking their blood pressure, or it may be at other times, and it may be that your practice nurses, if they're doing immunisation, say for the influenza vaccination, could also palpate the patient's pulse at the same time. And then, you know, if they think it's irregular, an ECG could be performed. But a medical quality ECG is the gold standard to make the diagnosis. There are devices that can do that, that aren't the standard ECG machine. And you'll of course have had patients who say, well, what about my Apple Watch? Can that do it? And we'll come back to that perhaps further in the discussion. But as I understand it, the Apple Watch that has a built-in ECG is not yet available in Australia. And I saw there's a recent study from the Cleveland Clinic in the US where they compared the Apple Watch 4 to ECG in patients in hospital, and the rate of pickup of the Apple Watch 4 was only about 40% of people who had AF on their monitor. So it wasn't fantastic in that study. But nonetheless, you will certainly have patients who occasionally come to you and say, oh, my Apple Watch has detected something odd. What do you think? And you might find they're in AF. And I've certainly had that happen to someone in the practice I work in, exactly that scenario. Okay. So, so she has asymptomatic AF. We do this screening and lo and behold, her pulse is irregular. And we do a 12-lead ECG and it confirms that Mrs. RC is in atrial fibrillation. So what are the next steps to the diagnostic workup of this finding? What would you do next to look into possible causes and things that might be treatable, which could be contributing to her heart rhythm abnormality? So the diagnostic workup that's suggested from the guideline includes a full blood count to make sure you're not anemic, obviously, and to look at the size and shape of the red blood cells, white blood cells, etc. Electrolytes, obviously you're thinking about electrolyte abnormalities there, fairly uncommon, but could be there. Renal function is important, both for any thoughts about therapy and because, you know, if someone's got a heart irregularity, they may have other vascular problems. Thyroid function is important as well because hyperthyroidism, as we all learned in medical school, can be a cause of atrial fibrillation or people going into atrial fibrillation. Important here, though, that the thyroid function is assessed when the patient's well, because in an acute situation, patient's acutely unwell and in hospital, maybe an infection or some other problem, their thyroid function may appear abnormal, but then revert to normal or show up as normal when that particular intercurrent illness has passed. And there's a role for transthoracic echocardiography that can identify valvular disease, which might not have previously been recognised, as whether it's atrial stenosis, mitral incompetence, whatever it might be, and to also look at left ventricular function. So, what's the ejection fraction, what's the left ventricular wall, what's the chamber size, and atrial size as well, because there may be atrial dilatation, atrial appendage. So, there may be signs that the atrium has been had some disease or had some abnormal changes for quite a period of time. Sometimes there will be a role for transesophageal echocardiography. That's particularly if you might be looking for thrombus, or the cardiologist looking for thrombus in the atrium, or for a left atrial appendage. And that's also relevant if cardioversion, electrical cardioversion or pharmacological cardioversion back to sinus rhythm is being considered as a therapeutic option. Now, clearly there will be cardiologists involved in any of these decisions, but we're giving you the overview here to sort of set out that process of thinking that goes on in that work. And then risk factors and comorbidities, and this is very much the realm of general practice. Weight management is important. We aim for some weight loss, typically around 10% of body weight, trying to get the body mass index under 27. So in our patient, it's a bit higher than that. And think about other cardiovascular risk factors, of course, how well controls her blood pressure, what are her lipids like, etc. Making sure she's not smoking, very important, alcohol intake. Obstructive sleep apnea is worth thinking about too, because that can be a contributor to atrial fibrillation, and it may make atrial fibrillation harder to treat if the person has significant obstructive sleep apnea, particularly if the apnea-hypopnea index is greater than 15 per hour. Exercise is a great idea, as it is for everything. We'd be aiming for exercise sort of over 200 minutes a week, and we aim to get her blood pressure down to a target of around 130/80, so maybe a little lower than you may have gone. Depends on other things, of course, but in someone of this age and without comorbidities, a target of around 130/80 at rest would probably be achievable. And lipids, as I mentioned, and alcohol consumption, quite a sort of severe deadline here of less than or equal to 3 standard drinks a week. So quite low alcohol. And all of these things help atrial health, or help cardiovascular health broadly, but atrial health to increase her risk of responding well to therapy, possibility of responding well to therapy, and for general cardiovascular risk reduction. So arrhythmia management. So this was an interesting discussion in the group, and it really is a kind of a two-strategy approach, that gets thought through. How is one going to approach a particular patient's AF, and what's the aim? What are we trying to achieve? And it really comes down to whether it's a rhythm control or a rate control strategy. I'll explain that a bit further in a moment, but a rhythm control strategy is basically, can we get this person back into sinus rhythm and maintain them in sinus rhythm, where a rate control strategy is accepting that that may not be possible, or too difficult, or too invasive, or not necessary, not sufficient benefit, and that a rate control strategy which slows the heart rate so that ejection fraction is improved and therefore symptoms are reduced, should be selected and documented. So there's a clear understanding of what we're trying to achieve, and that needs to be reviewed. It may not always be that one strategy stays for the whole of that patient's future. It may be that it turns out that a rhythm control strategy is not sustainable and the priorities or direction may change. So choosing that strategy, and there's influences on that choice. And rhythm over rate. Why would you choose rhythm versus rate? Well, patients that are younger and more physically active and more symptomatic would very likely get a benefit in terms of their function and their ability to be physically active if they were back in sinus rhythm. So that might make you think, well, let's go for a rhythm control if we can. Paroxysmal or early persistent AF, so it's fairly early in the clinical course of the arrhythmia, and it makes it more likely that getting people back into sinus rhythm will be possible and be sustainable. Left ventricular dysfunction, no severe left atrial enlargement. If there's severe left atrial enlargement, it's less likely that a rhythm control strategy will succeed, and it suggests that the problem's been there for quite a while. And adequate control over the ventricular rate's difficult to achieve. So, you know, if it's a rate control strategy initially, but people have still got a tachycardia and they are perhaps symptomatic, then that might also be a reason to consider the rhythm control approach. And conversely, a rate control approach may be where people are generally not minimal symptoms or no symptoms, and where, as I said earlier, trying to get people back into sinus rhythm is likely to be or has been futile. So you may have attempted it, maybe the cardiologist done a cardioversion or a medicated cardioversion, and that hasn't been sustained and the person's flopped back into AF again and may have happened recurrently. So going back to our case study and our management plan, routine checkup, the thyroid function, etc., are ordered. Which strategy would we choose? Well, I think we've covered a lot of this in terms of why you might choose one over the other. Younger patient are not symptomatic, so you could go either way. And something here where a cardiologist would and the discussion with the patient about what they want, of course, would be important. I think it's not clear that one's absolutely indicated for this patient. There would be some choices involved. So this is showing the algorithm for rate control, if that was the strategy we chose for this patient, and the sorts of medicines that are used for rate control. And you can see that it's beta blockers or non-dihydropyridine calcium channel antagonists, depending on whether there's known left ventricular dysfunction or clinical heart failure. So that helps you to make that choice. If there is left ventricular dysfunction or clinical heart failure, you'd be inclined to go with beta blocker. If there's not, you've got the choice of the calcium channel antagonists as another option. And then digoxin, which of course was the drug when I was a young doctor, because I'm not a young doctor anymore, was our standard therapy for atrial fibrillation and for rate control, is really these days an add-on for certain patients when you might need it. And it's, those people you're not getting the rate you want with the beta blocker or the calcium channel agent on its own. And you can see there's some other further options down the line there, which would really be, I think, where cardiologists would certainly be involved there in getting advice on AV node ablation, use of amiodarone, pacing, etc. So it gets certainly into the specialist area if you have a patient that's not responding to those rate slowing medicines. So as I said, second line agent in combination with the beta blocker or calcium channel antagonist. and you try to monitor, you do monitor digoxin level, and you try not to let it get above 1.2 nanograms per mil. You wouldn't use verapamil or diltiazem in the presence of left ventricular systolic dysfunction. Amiodarone, last line option, and the membrane stabilising agents would not be continued if they'd been put on those, because maybe initially they'd been a rhythm control strategy, and then this was being changed. Again, cardiologists would be involved. So moving on now to think about long-term rhythm control strategy. And I'm not really talking here about what happens acutely, in the hospital system when someone might present to the hospital with a new AF that becomes symptomatic and they've come with symptoms or been referred by you into for symptoms, because there's an acute care management thing there that may happen with acute cardioversion in some instances. But this is now thinking more about what about the long-term rhythm control strategy. Maybe someone's been in AF for some months or even years, or certainly some period of time. So you can see whether they've got structural heart disease is an important point for what choices of medicine that might be made. This is where perhaps the person's had a cardioversion electrically or by the use of the antiarrhythmic drugs acutely, and then they're in sinus rhythm, and how do you kind of keep them in sinus rhythm? And so this is a guide on the choice of medicines that are used to try to maintain sinus rhythm in the longer term. And again, as I said earlier, cardiology advice would be present here. And you've got flecainide or sotalol on one side there if you don't have structural heart disease, amiodarone if you do, and then thinking about second line options if it's not sufficiently controlled and the people are going back into AF. And catheter ablation, as you can see, is an option, either if the drug therapy fails or sometimes directly after discussion and patient preference and a range of other options which would be considered for going to that in a more direct way. So long-term practice points here on long-term rhythm control. Amiodarone superior efficacy over the other antiarrhythmic drugs, but potential long-term toxicities. Flecainide shouldn't be used in conjunction with an AV nodal blocking agent, so things like diltiazem or verapamil or a beta blocker. Sotalol has a modest efficacy in maintenance in sinus rhythm, and you can get this phenomenon called torsade de pointe, which is a ventricular tachycardia, which occurs particularly in patients who have a long QT interval. And that might be due to drugs, or it might be congenital that they have a long QT interval. Again, cardiologists would be involved here. And beta blockers are generally regarded as less effective antiarrhythmic drugs in the maintenance of sinus rhythm. Just a general comment is that long-term rhythm control, we're not talking about this working for every patient. Its effectiveness is modest. When it does work, it's certainly great because people are in sinus rhythm and better exercise capacity, less symptomatic, but it's by no means all patients where this will be successful. So, a lot of top content there, and certainly, refer back to the guideline because this is fairly detailed, and of course, in general practice, being generalists, we see a whole variety of things, and not every patient we see will have a cardiac problem, and so we need to kind of use those guides to help us. I'm going to move on now to thinking about stroke prevention, which is the other, of course, huge issue in atrial fibrillation. How do we prevent people from having strokes? And the basis of this really is using the CHADS VA score and assessing and correcting what we can in reversible bleeding factors. Can't always do everything, but not everything's reversible. Shared decision making about anticoagulant use and which one, and monitor therapy regularly. So the CHADS VA score, C is about whether they have congestive heart failure, whether it's preserved ejection fraction or reduced ejection fraction. and a history of heart failure or recent symptoms. Hypertension, whether or not it's currently elevated, age 75 or more, history of diabetes, stroke or prior TIA or systemic thromboembolism, vascular disease such as myocardial infarction or peripheral arterial disease or aortic atheroma, and age 65 to 74, a second age group as well, which is a different risk strategy to the over 75 age group. And you'll notice in this, it doesn't really influence the scoring and the risk, whether it's a male or a female. And that's why the sex of the person is not in the scoring for this scoring system. So what can we do about bleeding factors? Well, we can do a bit. We can try to reduce or control blood pressure. We can do what we can about frailty and falls, and obviously, trying to maintain physical activity, thinking about trips, hazards in the home, thinking about patients' vision, etc. Impaired renal or hepatic function, so we try to avoid medicines that might impair renal function, like non-steroidals. What can we do for liver health? INR, so making sure that their clotting is normal and they haven't got a coagulopathy to start with. Peptic ulceration, so if they have a peptic ulcer, treat it. They've got Helicobacter, try to get rid of that. Reducing alcohol use, making sure they're not anemic or iron deficient or both, and medicines that might increase the risk of bleeding. And things like non-steroidals come to mind, but there are others as well. So, there are some things we can do. We can't change people's age, and we can't change past history of peptic ulceration, but there are some things we can do that may influence their future risk. So moving on to back to our case study again. So the Mrs. RC's CHADS VA score is 2. And that would generally be regarded as a threshold to advise anticoagulation on the basis that the benefits in terms of stroke reduction outweigh quite definitively the risks of bleeding. And the grade recommendation on that, on the evidence review done for the guideline panel, was that rated the quality of evidence on that as high, and the grade of recommendation is strong. So there was a fair degree of certainty that that is to the patient's benefit to be anticoagulated, unless, of course, there's some overwhelming bleeding risk or bleeding risk which is you cannot manage. And you would even consider it in the CHAD-FAS score of 1, but the grade of evidence there is less certain or less strong. It's moderate, but the strength of recommendation is strong, but not quite so definitive. And then in someone whose CHAD-FAS score is just 0, there was you could even consider it there, but the recommendation strength was weak. Shared decision making. Here to think about what to do, and I've largely covered this in the discussion. 0. Probably wouldn't be recommending it. You consider it in score of 1, and you would recommend it in score of 2. Now, option for which anticoagulant? I think we live now in a world with the newer anticoagulants, which certainly have made life a lot easier in terms of the patient's life in taking anticoagulant, and our lives as GPs and clinicians in needing to monitor, because as we all know, warfarin monitoring is quite a lot of work for everyone involved. So the non-vitamin K oral anticoagulants are very much the medicines of choice in terms of anticoagulation. They're as good as or better than warfarin in reducing risk of stroke. They have lower risk of intracranial hemorrhage, and as I said, they're a lot easier for patients and physicians to use. Monitoring of therapy, quite a few patients just stop using them, and that's an important point. We may not realise our patients have stopped unless we ask, but it's 1/3 to a half of patients discontinue within 2.5 years of initiation. So there's certainly a need for continuity of care here and a follow-up, and trying to understand why that might be that people stop using the medicine. And trying to really think about those patient-centered strategies which would help people to understand the importance of this and how it reduces their risk, and how we could support them to continue to use those medicines. And monitor renal function is important. It doesn't have to be done very frequently, but at least once a year, because you would want to know if people's renal function was deteriorating, whether the dose needed to be adjusted. As I mentioned, the sex of the patient doesn't make any substantial difference to their risk of stroke, so that's why we don't need male or female status in the scoring. It may change over time. That's a good point. Of course, that stroke risk can change, and ageing, new comorbidities that may increase risk, other cardiovascular disease emerging, and so we do need to have at least an annual review of these patients to sort of make sure we're on the right track, and to think, do we need to change our therapy? Do we need to get advice? Are there other issues that we need to consider? Minimisation of bleeding. Often those two things go together. Patients being high risk of stroke may have things that make them a higher risk of bleeding as well. And so you're kind of doing a bit of a juggle. But the net clinical benefit almost always favours stroke prevention over major bleeding. And, you know, I think we do need to, in our consideration of those, balance those risks and look at the evidence, which in most instances would favour using anticoagulants, particularly the NOACs, given their lower risk of intracranial hemorrhage. And treating reversible bleeding risks be prioritised to minimise the bleeding rate. And things, as I said, like making sure we've treated peptic ulceration. People can be on a proton pump inhibitor that can further lower the risk. So there are sometimes things we can do that, you know, even a person who has, you know, esophagitis or gastritis and they're at risk of getting another ulcer, then use of some therapy may help to prevent that happening. So stroke prevention, just a few more practice points. So that's our key for determining whether to use anticoagulation. Asymptomatic patients may are just as high risk, so we would think about it in them as well as the symptomatic. Atrial flutter have slightly lower risk, but the risk still exists. And so the recommendations for atrial flutter are actually the same as for atrial fibrillation in terms of whether to anticoagulate or not. And the risk for patients with implantable devices and incidentally detected AF is lower in the general AF population. So the stroke risk may be slightly lower in those patients. And we need to, if patients have a transfer score of greater than 2, close follow-up for development of clinical AF, and consideration of that if that becomes persistent for more than 24 hours. So that is people who are at risk of stroke may develop AF, and may already have AF when we first see them, but they may develop AF. Okay. So I'm getting near the end. Optimisation of anticoagulation therapy. So point of care INR measurement clearly for people on warfarin is very helpful. A lot of us do that in our practice, and it enables us to make that decision about adjustment without having to wait for the lab result and then phone the patient back. And so that there is certainly a value for that. And, you know, and particularly if who are in an acute situation where a timely result is really helpful to know what to do. And we've talked about assessment of bleeding risks and ischemic risks as well. And sometimes, and this is again something a cardiologist would likely be involved in, people who have coronary artery disease have had a stent, perhaps, or would need to have both dual antiplatelet therapy related to their acute coronary syndrome. And so there's some uncertainty and some clinical judgment for sure involved in deciding on the use of dual antiplatelet therapy in these patients, and even when some people may need to have anticoagulation along with dual antiplatelet therapy. So this is a bit more about that, combining anticoagulation and antiplatelet drugs, and is something I think really would be where you'd be getting cardiological assistance. As you can see in the guideline, there's a figure on that, and when would be some of the indications for that, and for what length of time that would be considered after, say, a cardiac event or a stent. Short as possible broadly, and we've talked about gastrointestinal bleeding and the use of proton pump inhibitors. And where dual antiplatelet therapy is required in combination with anticoagulants, aspirin and clopidogrel are the recommended medicines, not the newer novel agents. And there's more advice about discontinuation after stent implantation or acute coronary syndrome or both, and then just continuing the oral anticoagulation alone after a 12-month period. A few words on integrated care. I mean, we've talked a bit about the role of the GP here and the role of the cardiologist, but of course there may be many other health professionals or a number of others involved. People who are trying to help the patient to get to a normal weight, people who are trying to help the patient to do exercise, and so a team of people may well be around this person to help them to achieve those goals. Shared decision-making, use of e-health, targeted patient education. There's a lot for a person to take in here, and this developing those goals in partnership with patients and communicated to their both members of the team and their family and their carers if they have a carer, and then regular monitoring and feedback and adherence, because as I said, we know from the literature that quite a few people stop for example, their oral anticoagulants and would be at risk of having a stroke. Right, I think we're up to the Q&A section now, where Atif and I were going to have some discussion about some issues that arise from that, and we'll see if we can answer some questions that you might have in the course of that discussion.
Okay, thank you, Nick, for that great presentation. We have I think we have time for Q&A now. It was interesting, actually. Let me start here with one of the issues we've seen since the introduction of NOACs is around the dosage, appropriate prescribing, especially from general practice point of view. Can you just talk about the key common problem to avoid and how best to optimize appropriate prescribing?
Yeah, well, I think, as I said, adherence is probably the key thing, and not assuming that, people have been adherent. And routine monitoring, we want to do a blood count and liver function tests at least annually, and also check their renal function, because we may need to do a dosage adjustment for some of the medicines in that instance. Yeah. Side effects, not usually a problem, but we certainly want to ask about those. And thinking about medication review and interactions would be the other issue to consider. Again, not as major an issue as with warfarin, where of course we always had to think about all sorts of medication interactions and alcohol and dietary change, etc. But there is still the need to consider all of those things when we're having someone on a NOAC in a long-term way.
I guess as well, the regular monitoring for those kind of patients definitely, and the GP would be in a good position, a better position to monitor those patients closely. secondly, we know that many of our patients with AF come with other cardiovascular disease history. Just I would like to hear from you about the role of echocardiography and when should it be performed.
Yeah, well, I think, anyone who presents with AF, you think, well, could they have other cardiovascular disease, whether it's coronary artery disease, whether it's valvular heart disease, etc. And an echo, transthoracic echo, is pretty easy to organise. These days, fortunately, in most places, not so much in rural or remote perhaps, but certainly in regional and urban areas. And that can help us to look at the valves and look at the ventricular function, look at atrial size. And it gives a picture of how the heart's functioning and whether there's other things going on. Because obviously, if they've got valvular disease and it's non-valvular atrial fibrillation, that changes the management quite a lot. And we've really been talking about non-valvular atrial fibrillation today. That's an important point that I should have made earlier.
So I guess the echo can just lead our management strategy here, whether the LV dysfunction or without LV dysfunction, which is a key point for management. I guess you touch base on people with the dual therapy with anticoagulation and antiplatelets. One common issue we see in clinical practice are patients on anticoagulants that are needing to have a procedure. GP usually face that sort of even in the routine normal practices. Someone with a skin lesion comes when he's on warfarin or he's a patient on NOAC, and he needs to have this skin lesion excised. Nevertheless, as well, going into colonoscopy, gastroscopy, and they ask the GP about whether he stops or what he can do for the anticoagulation. So can you get us just briefly on how we can, what we'd like to GP to advise patients going into procedures and they are on anticoagulation?
Yes, I think this is something that finds quite challenging and quite common and getting more common in general practice. I know just in my practice, we had a discussion around this the other day. I guess a general thing is we always need to weigh up the risk of an event versus the risk of bleeding. And procedures, the risk of bleeding is quite low, but the risk of the event, of course, is also lowish, but it might be much more substantial long-term damage. So for things like dental interventions, cataracts, glaucoma, endoscopy without a surgical thing, just a normal endoscopy to check on the state of the stomach and previous ulceration or what it might be, that would generally think no need to stop the anticoagulation. And even where there's intervention with minor bleeding risks like a endoscopy with a biopsy, sometimes the gastroenterologist would be quite happy to do that with continuation of the anticoagulant pacemaker insertion as well. Most of the cardiologists would be happy to do that without stopping the NOAC. But then if you're getting into things with major bleeding risk, catheter ablation, for example, of the atrium, orthopedic surgery like a hip replacement or knee replacement, very vascular organs like the liver, if you're doing liver biopsy, that would be something where pausing the anticoagulation and doing other options is needed. So it depends on the nature of the surgery. I looked on therapeutic guidelines, quite useful, and they've got a list as an appendix you click through, which comes from the US, about a whole range of procedures and rating of risk that the many US surgical and other colleges have done. Quite a detailed document, but there is more information there if you want to look.
And I guess as well, one of the key issues is just communication with the operator or the surgeon or the specialist is very common, is very important pre-operatively, whether they will be possibly on individual basis. I guess that leads us to maybe one of the last questions we have. It's In our practice, our patients usually asking about technology, as we might touch base on that with the Apple Watch. Since the advent of COVID and our increased use of telemedicine, it would be good to hear your thoughts about evidence for those types of devices, not necessarily the Apple Watch as well, but any other devices might help and might be useful ways to, as a telemedicine or technologies can be used in patients with atrial fibrillation for diagnosis, for screening in your clinical practice.
Look, I think this will come, and it's coming very rapidly. Won't be very long before we are doing, telehealth consultations, and we've got some sort of home monitoring set up where we'd be able to, see the patient's heart rhythm in a reliable way. I don't think we're quite there yet, but I think that will come, and it will make, in some ways it'll make access to care easier, and for the patient certainly, and I hope also for the decision making for the medical practitioners involved as well. But I don't think the technology is widely available yet that could do that, in 2020. But I think we're talking 2 or 3 years' time, I suspect we would be saying, yes, that's now, out there in the community.
Yeah, I just want to, maybe I agree. Personally, actually, I just want to show you something like that machine. And I can use it in our practice, and it's wirelessly connected to our mobile device, and it's fantastic. Just give it the rhythm, and instantly, whether it's regular or irregular. Definitely, one of the takeaway messages here is I would like to emphasize on the clinical examination. Simply just feel the pulse and can save lives. Actually, as maybe you touched base on that in your first few slides. Just feeling the pulse can save lives and prevent strokes. Ongoing regular monitoring, educating patients with regard to the purpose of various treatments is important to ensure compliance and adherence to that treatment. Share the decision with patient and cardiologists and general practitioner is one of the key issues as well for management and I guess in atrial fibrillation. I guess that takes us to the end of our session today. I'll hand over to Amanda. Thanks, Nick.
Thank you, Adam.
So thank you very much to our speakers today, Dr. Asham and Professor Svar, for such an interesting presentation and discussion. If you'd like to see any more of the resources that have been discussed today, please go onto the Heart Foundation's website, where you'll find the clinical guidelines, a brief article summarising the central role of the GP in atrial fibrillation management, and as well as some of our patient resources, including some brochures, information about our helpline, where your patients can speak to a qualified health professional, and also some information on our website is about things like looking at your local cardiac rehabilitation service, as well as walking groups, nutritional information, and also some action plans of where you can help patients improve their lifestyle and heart health. Also, please don't forget to download the Smart Heart Guidelines app, so you can always have your clinical guidelines close to hand. So thank you, the audience, for also attending the session today, and we look forward to seeing you again in one of our future sessions.